Now ultimately what is this link? When we talk about specialty on one side and another specialty on the other side, and there is a link in between. The common link is the inflammation. When we pass out our first MBBS and go for the pathology class, the first chapter or first topic taught to us is inflammation. And some GM side sitting here will agree with me that chapter of inflammation is taught by, used to be taught by Dr. R.K. Gadgil, the professor of cardiology and pathology that time. So it was such an important thing. Inflammation is the main basis of all diseases, pathology, or what we call pathophysiology also. To recapitulate the link between joint involvement and cardiology, you can start with rheumatic fever. Rheumatic fever gives rise to heart disease. It starts with joint pains, fever with joint pains, and typically involving the larger joints. We call it licks the joint and bites the heart. Joint involvement is in the childhood, and the walls of the heart are affected after 10 to 15 years. Yeah. That's the link. Of course, the link is between heart valves and rheumatic fever or joint pains, whereas here we are having a link between osteoarthritis and coronary artery disease. But ultimately, the link is on the basis of inflammation. They call it fleeting joint pains. The typical character of rheumatic fever is fleeting joint pains. It catches one joint, swelling, inflammation, redness, pain, loss of movement. That recovers and then it goes to the next joint. And there is a classical history of fleeting joint pains. Many times, the history of rheumatic fever is lost. Patient just directly comes with valvular heart disease. If you go into the details with this particular history, majority of the patient will come out. Although 50% of patients may not have the history, but those who had, they will agree that they had such type of typical joint involvement. Even drugs, diseases like bacterial endocarditis, always an infective process, but the involvement of the other systems is because of autoimmune. That's what happens. You get joint pains. Rheumatoid arthritis, the Eberton's nodes also commonly associated with heart disease, not necessarily coronary artery disease, but aortic regurgitation is common in patients with rheumatoid arthritis. And obviously the ups and downs of inflammation that we see, the relapse and remissions, and the treatment for rheumatoid arthritis is the disease modifying drugs. They don't cure, the disease modifying drugs. So they also may have some side effect profile. And therefore, there is a strong correlation between joint involvement and heart, and most important thing, of course, since I made a reference to phagocytic is uricosuriia. We don't wait till the patient develops gout. Now, gout is again an inflamed joint. There is no infection in that. It's a red, inflamed, painful joint, but no inflammation, no sepsis over there. That's because of hyperuricemia. And then nowadays we consider hyperuricemia as a risk factor for coronary artery disease. When it comes to listing like diabetes, hypertension, and all those things, dyslipidemias, regularly we ask for serum uric acid estimation before the patient can develop gout. So the question that we raised, if they are going for joint surgery for osteoarthritis, the cardiologists have to give a fitness. It's a good thing that we will all take the patient for angiography first in order to convince the anesthetist to take the patient for the fitness for surgery, and vice versa. That if the patient comes to you with osteoarthritis, we'll always investigate it from the point of view of the coronary arteries associated. Now that gives a clue that how to investigate this patient. Now to go back to the rheumatic heart disease, we always go for the inflammatory markers like the C-reactive protein, the ASO titer is extremely important, and the treatment also is based on that. If you start aspirin and steroids to these patients, we always monitor the ESR, the C-reactive protein, and the ASO titer in order to see that the patient is responding well, to prognosticate the patient. And these inflammatory markers are also useful in future life also. To quote an example, the famous Jupiter trial, where healthy individuals were picked up and studied for dyslipidemia. They found that those patients who had high LDL cholesterol, they wanted to give statins to this patient in order to prevent coronary disease or future coronary events. So they picked up all those patients who had high cholesterol, LDL cholesterol, and estimated their HSCRP. I'll send you to CRP. Then all those patients who had high LDL, all those who had high HSCRP were given empirically or having told to them that this is going to prevent your future event. They were given 20 milligrams of rosuvastatin and they found significant reduction in future coronary events. Healthy individuals who had no complaints about coronary artery disease. So that itself again highlights the main basis as inflammation in whether it's or whether joint involvement or whether it's coronary disease. So HSCRP is very important, and even later on also we have the HOPE-3 study also where they have studied that. So that's extremely important. So just let's go quickly some of the slides. Some may be a repetition also. So this is the correlation between osteoarthritis and coronary artery disease. See, two conditions which are commonly seen in elderly population is hypertension and osteoarthritis related to the age, so to say. But there are other factors also we routinely investigate, like diabetes, dyslipidemia, in these patients, uric acid estimation, apart from these. And as rightly said or stressed heavily on obesity. Obesity has got a vicious cycle. Obesity itself gives rise to osteoarthritis. And a lot of joint replacement surgeons are reluctant to operate on the patients because they say unless you reduce weight, you will not be able to, you will not going to be benefited by surgery. And because you are overweight, you may not go for regular exercise and all. And obese patients have what is called a metabolic syndrome in our language, especially when they have a frontal obesity or abdominal obesity, high BMI, they develop diabetes, they develop hypertension, they have got hypertriglyceridemia. So all this combination of various risk factors itself make the patient prone to develop coronary artery disease. So these two factors already we have discussed. Then there are various studies for and against where they have proved that the osteoarthritis and cardiac involvement of coronary artery disease is quite common, which Abhay also referred to. So that gives you a clue or gives you an idea that you must take a hint from these patients who can be with joint pains. Now, the point that he raised was those patients who cannot walk. So we are also helpless. Those patients who cannot walk because of the joint, we cannot subject them to stress tests in order to diagnose whether they have coronary artery disease. The ECG may be normal. We must take advantage of other investigation by which you can pick up coronary artery disease, like say CT coronary angiogram, which is possible nowadays with us. Then there is contrast echo, which is available, which can also help you to diagnose patients with asymptomatic coronary artery disease only because they have a joint involvement. See, these many RTC trials, randomized controlled trials, have shown that there is a correlation between osteoarthritis and coronary artery disease. Prevalence, of course, we discussed. This is the common diagram which I show in a crowd where there are physicians and cardiologists. This is the vascular endothelium. We are just again coming to the same theory of inflammation. How does atherosclerotic start? This is the vascular endothelium. There is an endothelial dysfunction. Because of that, there is monocytes entering into the subendothelial area. These monocytes engulf the LDL particles, what are called small dense particles. And they become very fat, and therefore they are called as the foam cells. Because the engulfing of the LDL particles, they become foam cells that raises the endothelium slowly and slowly, and the lumen of the artery becomes narrower and narrower without the knowledge of the patient. We have seen sometimes in coronary angiogram that the arteries are 100% closed. Patients are not suffered heart attack because when there is a closure which is very slow, the body has a time to take the advantage of natural bypass or what is called a collateral circulation. And therefore, even if one artery is closed, the other two arteries are able to supply the heart and maintain the circulation. Now, problem comes is the inflammation. Inflammation is the first thing. Therefore, most of the conditions where we talk about vasculitis, like say periarteritis nodosa, diabetes is a vasculitis. As soon as you diagnose a case of diabetes, he's already got coronary artery disease. You presume that. And therefore, lot of people or lot of associations like the American Diabetic Association and the Indian ones also recommend that any patient who got diabetes at the age of 40 must receive a statin. I'll come to that afterwards. I made a reference to rosuvastatin because statins not only reduce the cholesterol but also have anti-inflammatory action. And that the inflammation at a vascular level is taken care of. The process of atherosclerosis is delayed. Now what happens that if you have a plaque which is only a 30% occlusion of the vessel, for some reason because of tachycardia, fluctuation in blood pressure, fever, some other cause, that plaque ruptures, what we call is a vulnerable plaque. Why a patient who's in hale and hearty, went to sleep, didn't get up in the morning, patient comes from the office, hale and hearty, has a dinner, suffers heart attack and unable to reach the hospital. So explanation for such situation is that a 30% plaque ruptures and there is a chain of reaction, chain of events which makes the human 100% by virtue of the rest of the 70% like to have another event afterwards also. So therefore over the years what Dr. Kumla referred to the stent technology is the idea of opening that plaque and then place a stent over there in order to prevent the reclosure. In an acute situation, we perform what is called PAMI, primary angioplasty in myocardial infarction. The vessel is 100% blocked. You pass a wire, open the vessel, dilate it with the balloon and then put a stent over there. The vessel is 100% open. The death of the muscle is prevented, provided you do it within the 90 minutes, which is called as the golden hour. Patient suffers heart attack within 90 minutes. If he reaches a cath lab and the intervention cardiologist with his team is available, the artery can be opened and the patient life can be prolonged. Otherwise, during our undergraduate days or even our residency days, the mortality of acute infarct in the first 6 hours used to be tremendous. There was no facility of ICU also. ICU started by about 72 or so. So that is the theory of inflammation again. And then I come to the reference. Look at this. That with a lot of hormones, vasoactive substances, they all are responsible for the inflammation at the endothelial level, endothelial dysfunction, leading to atherosclerosis and therefore incidence of coronary disease. Obviously, I have already touched. Physical inactivity is already talked. Physical inactivity leads to obesity. Physical inactivity, they are interrelated. You don't get a proper control of diabetes. Physical inactivity, the blood pressure also is difficult to control. Physical inactivity, again, control obesity, metabolic syndrome, and so again, most of the things are repeated. What I wanted to draw attention is the NSAID, of course, direct side effects are not there as far as heart is concerned, but they may be active through the kidney. They are nephrotoxic. And there we come to another link that those patients who have microalbuminuria, there is a link that these patients have higher chances of future cardiac events. Whether it is because of diabetes or otherwise, that is one clue in a patient. The kid his creatinine may be normal, his EGFR may be normal, but microalbuminuria, simple test, you get a paper test and you can pick up. And those, of course, proteinuria is a different issue. Again, another clue for future cardiac events. If you treat at that level, these can be picked up. So microalbuminuria and NSAID use, COX-2 inhibitors. So again, follow the clinical practice of guidelines, mechanisms, NSAID should be avoided, and use alternative what we already discussed. Now, common etiology of inflammation. As I mentioned earlier, the inflammation markers are available. There are various markers which are available, and therefore we have been using statins. Now, what is the use of statins in a patient who's got inflamed endothelium, who's got a ruptured vulnerable plaque? Now, what is called a vulnerable plaque is one which has got a soft core. The plaque which contains fat is a soft core, it is vulnerable to rupture. But one which is a chronic one, which is covered by a fibrous cap, that is not vulnerable, it becomes a hard one. Even if the artery is narrowed, patient doesn't suffer from anything unless the other two arteries are also narrowed, and therefore there is a compromise between demand and supply. When they walk, they get angina of effort. So that is where even the fibrous cap of the atheroma also can be symptomatic. But what statins do is they stabilize the plaque. They have an anti-inflammatory effect, so inflammation is under control. They stabilize the plaque, making it more firm to hard and not vulnerable to rupture. So this role of statins, irrespective of normal lipid level, normal cholesterol level, most important. And that was the main use of all those asymptomatic individuals in the famous Jupiter trial. Therefore, when a patient suffers a heart attack, without estimating his lipids, without asking for lipid levels, we always ask the referring physician or the family physician to give 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin, 300 milligrams of soluble aspirin in order to prevent the clot formation, and 300 milligrams of clopidogrel, which will prevent the clot formation, and atorvastatin will take care, or rosuvastatin will take care of stabilizing the plaque. That's extremely important. This is what happens. These are the few culprits of inflammation again. And how does rosuvastatin work? Adrenaline levels. Look at this. Baseline levels after therapy, they are gone. Only rosuvastatin increase the serum adrenaline, they are significant. And HSCRP was brought down. Reduction in HSCRP was greater with rosuvastatin than atorvastatin. The comparison, of course. So these inflammatory markers help us to prognosticate the patient, help us to diagnose also, and that's why rosuvastatin or atorvastatin, the statin becomes the mainstay of treatment of all those patients who are higher risk. This, of course, he made a reference to patients with osteoarthritis who undergone surgery for wall replacement. But their prognosis is better, their events, future events are controlled. Maybe, probably these people were not walking earlier. Now with the joint replacement, they are able to walk, undergo exercise. Now a lot of joint replacement surgeons show that my patient is playing tennis also, and ladies are dancing also. Okay. So that's how maybe activity is encouraged, and patient gets a confidence that he can do the activity. So that's why there are studies which are for and against what happens after joint replacements. But that only shows that there is a link between joints and the heart, coronary artery disease, and inflammation probably is the underlying factor. Extremely important. All those patients who are diabetic must suspect associated coronary artery disease. And angiogram is always top as a gold standard. Again, when I come to the vasculitis part of it, both venous and arterial thrombosis can take place. Conditions like, say, polyarteritis nodosa, ACL, and all those things. And post-plasty, why? And arthroplasty or joint replacement, they encourage the patient to walk immediately because they have a fear of getting deep vein thrombosis, which can kill a person by pulmonary embolism. So encouraging these people, then tying the tourniquets, etc., their equipment also. So time will not permit to go to this. Prevention of deep vein thrombosis following surgery, extremely important. Not directly related to coronary artery disease, but prevention of pulmonary embolism. There are various drugs, age-old warfarin, then we have rivaroxaban and dabigatran, which are regularly being used nowadays as a prophylaxis and treatment. These are the various methods by which you prevent deep vein thrombosis, more of a orthopedic talk. Then there are other newer drugs which are not available with us, but they are being experimented. So it's mandatory to assess hospitalized patient for deep vein thrombosis and prevention of pulmonary embolism. Then prophylaxis, of course, the exercises, muscle exercises as a prevention. We always talk about prevention is better than cure. So to come to the last slide of summary, the cardiovascular disorders, mainly coronary artery disease and osteoarthritis, have a common thing that when you suspect one, you must suspect the other one also. Whichever is the first can give you the clue to investigate the other one. So, in other words, there is a definite correlation between osteoarthritis and coronary artery disease, not necessarily age-related, but proved scientifically also by various studies. So every osteoarthritis patient should be investigated from the point of view for coronary artery disease and vice versa. Side by side continuing treatment for both individually. The treatment which for the joints is already discussed. Treatment coronary artery disease is another lecture which can discuss totally, but one must, it is always by high suspicion that you can pick up such thing. Hypothyroidism or hyperthyroidism condition which is very difficult to suspect. Patient moves from doctor to doctor and suddenly somebody strikes, this could be this, and you pick up that and patient feels, oh, this doctor is great. So similarly, that as you say that the medical science is science of research and innovation, in all these patients, you must investigate them from one from the other, whenever, in whatever condition they present to you. Thank you very much for your attention.